We are very happy today once again to conduct our ECHO session. We all know that is the platform that we do individually so that we can capacitate one another for a better care of our clients, or our patients, and our facilities. My name is Samuel Mukele from Hospice at Home. Today I'll be the facilitator of this session. We are lucky today. We are happy. We do have our participants. Today are few as compared to the other days that we normally at our sessions. So before we commence, I would like us to introduce ourselves. Maybe I will start from my colleagues there at Eswatini Hospice at Home to just introduce themselves. Then we will continue from there.
Good afternoon, everyone. My name is Palliative, Senior Nurse Hospice at Home.
Good afternoon, colleagues. I'm Pius Mwaya, Eswatini Hospice at Home.
Afternoon, team. I'm Sandile from Eswatini Hospice at Home.
Good afternoon, colleagues. Nonudu Zotani for Eswatini Hospice at Home.
Good afternoon, colleagues. Good afternoon, colleagues. Afternoon, colleagues. My name is Lovana Bitepa.
Good afternoon, colleagues. My name is Nancy Shaban.
Okay, thank you so much, Tim. I see Tandazile Smelane from Manzini Government Hospital. May you please introduce yourself, Mboni?
Good afternoon, Tim. I'm Tandazile Smelane from Manzini Government Hospital. For now, I'm joining alone. I think the rest of the team will be joining later. It's quite a busy day up here today.
Okay, thank you. I also see Professor Wilson Akuda from Uganda. May you please introduce yourself? Professor, are you there? May you please unmute yourself? Okay, maybe it's still coming. I will move to Malaika. May you please introduce yourself? Okay. In the interest of time, we will continue. It's just a quick reminder to the phones. May you please remind all the phones should be switched off to a certain mode or vibrating mode so that we cannot disturb our session. Also, I would like us I would like to remind the team that you do indicate on the chat box your name and your surname and your destination you work for. You just indicate there whatever you'd like to say. It may be a comment, it may be a question. think we will respond to that as we continue with our session. I can also see Anna. There, may you please introduce yourself before we continue. Okay, let us continue. We are still colleagues on the same topic in management. Last week we did our session, the special population and the special populations and patient anesthesia. In the last session, we did that whereby we looked at the increased needs of special population. We learned that colleagues, these populations or these special population may include the immediate dying, the older adults, the cognitively impaired patients, and also the children. So also we looked in detail on that. Then we also shared the case study from Manzini Nazareth Hospital by Tandazile Sulemane. She talked about the patient. The case was about the 34 years patient. I think we all remember with the breast cancer, who did the surgery, mastectomy on the right breast. She also shared that the problem was the progression, despite there was a progression despite the surgery intervention from the hospital. Maybe because Tandazile is also here, can you please shortly give us an update? What are the updates for the clients? What have you done so far for the client that you presented her case in that session? Tandazile, are you there?
Yes, Mr. Keller. Thank you so much for the opportunity to actually update on what we did for the client since our last presentation. Amongst other things that were discussed were the issue of pain management, where we agreed that instead of giving the morphine 6 hourly, let's give the morphine 4 hourly, which was done because the client has been admitted sometime last week. And also the other concern was seeing the family. Initially, we had planned to see the parents, but then the family came with a sister, which she said she was comfortable us having discussion with. Actually, she said she's the one who is currently her caregiver. So they came and we had a chance to discuss goals of care with the sister. And the sister again shared the same sentiments. She felt like at this juncture, they feel as a family that it may not be the right time to actually discuss goals of care with the client, considering her condition. So yes, she did mention that Maggie and Babi were aware of the fact that she's currently on palliative and supportive care. Yes, and also that whatever chemo she's getting, it is just palliative chemo. And the issue of the dressings, yes, we discussed the dressings because when she came back, there was a bit of odor from the breast, from the wound. So we discussed how to take care of the wound, and also the fact that the wound may not necessarily heal, but it's just making the client comfortable and such that she's pain-free and it doesn't have the odor. So basically we did have a meeting with the sister. Also, we did work on the issue of pain management, and the client was discharged their home. And the sister is doing the daily dressings. Thank you.
Okay, thank you so much, Mbuni. Thank you for what you have just shared to us. I hope our professor can hear us. He is ready for us to take us through today's presentation, which is about managing pain in patients at risk for substance use disorder. So we shall be presented by Professor Wilson Akuda from Uganda. We are lucky today. So, and also the case will be from the hub today, will be presented by National ECHO-Eswatini from our region. So I think that will be after the presentation by the professor. Professor, are you ready for our presentation, today's presentation today?
Hi, Prof, are you available? Hi, Prof. Hi, Professor.
Professor, are you there? Sorry for that, colleagues. We are still waiting for Professor Wilson from Uganda. Yeah, I think he's still trying to connect. He's still trying to connect the platform. So we'll just wait a little bit. I'm afraid we have to start with the case presentation, but we cannot because we still have to hear from him. Okay. Let's just join in. Mr. Professor.
Hello. Hello, can you hear me now?
Yes, we can hear you, sir.
Okay, okay. So I was hearing you, but you were not hearing me. So let me put back the screen.
Yes, you can go ahead, Prof.
Okay, go ahead, Professor.
Okay, can you still hear me?
We can hear you, but your screen hasn't yet shown up.
You can't see the screen?
Yes, yes, Prof.
What's the problem now?
I heard you.
Hello, can you see the screen now?
Not yet, Prof. Maybe if you can start again and share it again.
Hello, can you see the screen now?
No, not yet, Prof.
What's wrong? They said they cannot see it. Problem now. Sure.
It's coming now. Okay, we can see it now. Maybe if you can put in presentation mode. Thank you. It's going.
Yeah, what happened? No, they can't see me.
Just disappeared. The probable under alone did that, Prof.
This start again.
Is it not him?
When the screen is there, they can't hear me. When the screen is not there, then they can hear me. It's some problem.
But I told the Prof to share the screen with us, but you see, go sit there and half fast. EPPA as a professor. Ngoba yona nje ngayamenyula kunalithabula sangenekile.
Wow, sitawa. Sekuthi nayo.
Mathi uyilanze kuma online na professor. Eh? Okay, we can see it now, Prof. I think maybe if we can go for presentation mode.
See it.
Which one on this? Which one am I?
No, I need to start from the beginning, yeah. That's not large enough. Okay, hello, can you see it now?
Yes, yes, Prof. Now it's fine.
Okay. No, they can't see me. Okay, sorry about that, the delay. Oh dear. Okay, sorry about the delay. Let me just introduce myself a bit more, if you can hear me. As I said, I'm Professor Wilson Achuda. I'm a psychiatrist by profession, but I've been working with Hospice Africa Uganda for the last 10 years. And most of the time, I have been the principal of the Institute of Hospice and Palliative Care in Africa. The Institute is the education wing of Hospice Africa Uganda, which trains palliative care specialists up to award of certificates, diplomas, degrees, and up to a master's level in palliative care. We are the only institution which does this sort of specialist training in Africa, and our students come from all over sub-Saharan Africa, except those from the Republic of South Africa. I'm glad to say that at least we have got one student at the moment from your country, from ECHO-Eswatini, who's doing a master's program. So thank you very much for inviting me to participate in your sessions. As I said, I'm a psychiatrist, but my specialty within psychiatry is substance misuse. And my work at Hospice Africa Uganda is mainly to offer psychosocial support to patients who need psychosocial support. So those are the outcomes of what I expect to cover with you today. I'm going to start with what is substance use disorders. Whenever I've talked about this subject of substance misuse, I find in the audience there are people who know a lot about substance misuse, and there are those who know very little. So what I'm going to cover really, I'm going to give you a background initially about what is substance misuse and the common type of substances which are used or misused in sub-Saharan Africa. And I will talk about the harmful effects of these substances. Remember that we are dealing with patients with pain in palliative care. So many of them are really having many medical, physical, health, and social problems. Now, all these substances, drugs we're going to talk about, have serious physical damage on the physical health and psychosocial status of the patient. So I will talk about each of them and also their physical health problem. And then I will talk about the risk. What happens if a person is presenting in palliative care with the pain is also dependent on drugs? How do you manage it? So that's where I will end by saying managing patients with substance use disorders in palliative care. So first of all, let's start with what is a drug and what's a substance. Already there are two definitions here. Well, I'm using the word substance misuse, But you know that many textbooks use the word drug dependence or substance dependence. So this has been a problem all along. Initially, the World Health Organization just used the word drug. But in recent years, it has been found that there are other substances which are abused or misused, which do not qualify for the definition of a drug. And an example here are young people who smoke petrol or glue and so forth. But by definition, the World Health Organization defines a drug like if any substance which, when introduced into the body, modifies one or more its functions. And this is how all drugs work, by modifying chemical functions within various parts of the body. They can lower blood pressure, they can treat diseases, they can do all type of what is required of them. So these definitions includes actually drugs which has got legitimate medical use. You know, like we are going to talk about morphine, penicillin, Panadol, paracetamol, and so forth. And those which do not have illicit or legitimate medical use, such as cocaine and so forth. The thing about the drugs that we are going to talk about here within this group definition of drugs is that there are some of them which has got what's known as psychoactive properties. Psychoactive properties means that when a person takes them, in addition to whatever chemical action they have in the body, they have effect on the mood. They alter the mood, usually makes the person feel happy and relaxed. And therefore, a person then have certain type of behavior which are associated with this abnormal state of mind. It is because of their effect on the ability to alter the mood and cause relaxation that this group of drugs are liable to misuse. They can be misused, they can be abused, they can cause dependence, and they cause addiction. Again, this is a word that whenever you read about drugs, which you find terminologies of drug use, misuse. Misuse just means that the person is taking this drug which alters the mood in order to solve problems. They are feeling unhappy, so they are taking the drug in order to make them feel happy, to deal with the problem. So they are misusing it. Abuse means that they are using it to the extent that it is causing them harm. Okay. And of course, when they continue to use or misuse for some time, it can cause dependence, what's known as dependence or addiction. And I will elaborate on this a bit more. Oh, sorry. So when we talk about substance use disorders, as the topic of the talking, we are saying that the person is using a drug or in such a quantity, the amount is taking the quantity and the frequency, using it so frequently, and has been using it for a certain duration of time, so that it begins to cause him harm, not to the person himself. It can also cause harm to the family and to society in general. So as we know, with any drugs like alcohol, when a person takes it once or while in small quantities, it does not cause any harm. But if the person begins to take large quantities and take it frequently, daily or almost daily, and they take it for a certain period, that's when it begins to cause harm to the individual and of course also to the family and to society. And that is when it causes what's known as dependent. They become dependent on the drug. So once they are dependent on the drug, that's when it begins to cause a lot of physical health and social and health and socio-economic problems. What does the word dependence mean? This word is used together almost in the changeable way with the word addiction. Now, addiction was the older words which was used to describe dependence. But in the last 20 years, the World Health Organization found that the word addiction is associated with a negative attitude towards the patient. So they prefer the word dependence, which would be more acceptable. But some textbooks still use the word addiction to indicate severe degrees of dependence. Okay. What does this mean when a person is dependent or addicted to a drug? Number one, it means that the person cannot control its use. People who take alcohol and so forth, they can take it when it is there. They can take it, they don't take it when it is not necessary to take it. And when they don't want to take it, they don't take it. But the person who has got dependence cannot control use. They can use it anytime, even whether they're working or in appropriate time. And so they cannot control the frequency of taking and the amount they use. And this leads them into problem. And the other feature of dependence is that the person continues to use the drug despite being aware that it is causing him harm. And the harm can be physical, psychological, social, or to the family. The next feature of dependence is that the person develops what is called as tolerance. Tolerance means that after the person has taken drugs for a long time, its sensitivity, its effectiveness reduces. So the person requires a higher and a higher dose in order to produce the desired effect. And it is when they are taking these higher doses or higher quantities that it can begin to cause severe physical damage to the body, which I'll mention in a moment. The next feature which indicates the person has become dependent on a drug is that when they stop taking it suddenly, they experience what's known as withdrawal syndromes. Withdrawal syndromes is the opposite physiological changes that occurs in the body, which is opposite of what the drug was doing. So the person who had taken a drug in order to feel relaxed and happy becomes very depressed, becomes very anxious, feels very sick, tremors, even experience psychotic symptoms. They become very, very sick. And so they know that if they take the drug again, it gets rid of the withdrawal syndrome, okay, symptoms. So this is the thing which actually gets them hooked in the drug. If they stop, they become very sick. The more they take it, the more they cause damage. So substance misuse disorder can be classified as mild, moderate, or severe. So what are just briefly, let me mention the other, in addition to the dependence syndrome, which I mentioned earlier in the previous slide, these drugs also cause problems by what's known as intoxication. If the person takes a certain amount very quickly, a large amount, they become intoxicated. And the example here, you have all seen somebody who is drunk, too much alcohol, becomes drunk, becomes intoxicated. And when they are intoxicated, they can cause a lot of problem, violence, accidents, and so forth and so forth. I already mentioned that once the person begins to take large doses of these drugs over a long period of time, it causes damage to physical damage to many parts of the body. I'll mention this again in a moment. And then the other problems, of course, is that it also causes psychological problems like depression, anxiety, even suicide. A lot of people who get substance use disorders end up committing suicide. Or sometimes it precipitates very severe mental illnesses, which are called psychosis. At the same time, prolonged misuse of substance misuse are associated with social problems like violence, economic problems because these drugs cost money, and criminal activity and so forth. So the wide variety of social problems. And it can reach a stage where most of these drugs can be smoked or drunk. But it reaches a stage where a person who has got substance misuse disorder find that when they take it by mouth or by smoking, it does not produce an effect. So they inject them directly into the vein. Okay. It is during the process of the injections in the brain that they can cause themselves blood-borne infections, such as COVID-19, hepatitis V, so not COVID-19, HIV/AIDS, and hepatitis C, B, and so forth. So there's a wide variety of problems that can be caused by drugs. So let me then just mention briefly, because as I said, when the patient in palliative care with pain presents to you, is having serious medical problems already, which could be a cancer, could be a heart disease, could be a kidney disease. But these drugs also cause severe physical health problem, as shown by in the case of alcohol, which is the most widely used substance in many parts of the world. But when taken in large quantities, it can damage any part of the body when taken in excess. It can cause intoxication. I've talked about drunkenness, which can lead to accidents, violence, and so forth. It causes damage to certain organs more than others. Liver damage, the stomach, ulcers, brain damage. It causes certain cancers associated with the cancers of the mouth, esophagus, of the GIT. It is a cause of high blood pressure. If a pregnant woman takes too much alcohol, it can damage the fetus, the unborn child, and causes what known as the fetal alcohol syndrome. In addition to that, alcohol is known to cause a lot of psychiatric disorders. There's a severe mental illness called delirium tremens, which presents normally in the mental hospitals. It is a major cause of anxiety, depression, suicide, paranoia, when the person believes that people are plotting to harm him, is a major cause of sexual problems, impotence, and so forth. And a common cause of a condition called morbid jealousy, which is much commoner in men, but can occur in women, where the man believes that his partner, his wife, or a sexual partner is having sexual relationship with somebody else. And this is a delusion. It's not real. It's just a delusion, an abnormal belief caused by alcohol. And this is a major cause of domestic violence, which sometimes result in a murder of the wife and so forth. Very common in African setting. I've already mentioned that alcohol damages the brain. So a person might find themselves seeing visions, having hallucinations, hearing voices of people are not there. It can cause a condition called dementia, where the person loses memory. And of course, as I said, it can cause addiction and tolerance and social problems. I've already talked about, you all familiar with alcohol causing domestic violence, financial problems, family problems, marital problems, and criminal behavior. So this can be added onto the problem presented to you in palliative care. The next substance, which are also widely used, of course, is tobacco. The substance in it which causes the euphoria, the feeling of well, is nicotine. It is a drug which is called a psychostimulant, which makes when the person smokes, they feel happy, relaxed, and increases their attention and concentration and so forth. But as you all know, prolonged smoking is a major risk of lung cancer. It also causes a lot of diseases of the lungs. It is a major cause of high blood pressure. It is a major cause of heart attacks, ischemic heart disease, and also contributes to a stroke. A stroke is when a blood vessel in the brain gets blocked and the person becomes paralyzed on one part of the body. And it is also known to be associated with increased risk of certain cancers, particularly cancer of the cervix, which is very common in Africa, and so forth. The next substance, which is extremely commonly abused in all over the world, really, but so more so even in the African setting, is cannabis. It has got numerous names which varies from country to country: marijuana, bang, hashish, dope. I'm sure in your country you also got names for this particular drug. So it is a plant which is very easy to grow and grows very easily in tropical countries. It has got about 55 different chemical substances which act on the body. But the two which are most well known, which I should mention to you, the first one, which is called delta 9-tetracannabinol, or just called THC. This is the one when people smoke cannabis, it makes them feel happy, it makes them feel relaxed, and makes them more sociable, and so forth. And this is why a lot of young people abuse, take it. But when taken very quickly in large quantities, it also causes intoxication, where the person becomes very confused. It can precipitate a severe mental illness, which a person normally ends up being admitted to a mental hospital, and it can cause addiction. That is why one thing. That's why cannabis is well under control by the United Nations. The other second very important chemical substance in it is something called cannabidiol, or CBD. Now, you must have been hearing a lot recently about medical uses of cannabis. Traditionally, all over the world, people have been using cannabis for treating a wide variety of illnesses, including pain and so forth. But it is now been shown medically through research that actually cannabis has got a role that it relieves pain. And we in Uganda, we have a lot of people with cancer pain who illegally you find using cannabis to control pain. It can cure a disease called glaucoma, which is a raised intra pressure within the brain, within the eyes, which can cause blindness. It can treat condition where the muscle becomes very stiff. It can control nausea or feeling sickness, which is associated with chemotherapy that you're familiar with. It has been found to be useful in controlling certain symptoms of HIV/AIDS, particularly relieving pain and improving the appetite. One of the main features of AIDS was loss of appetite, and therefore the person becomes very slim. But cannabis relieves pain, but also improves appetite so that the person doesn't lose weight. And it's also used for treating other neurological conditions, including certain types of epilepsy that occurs in childhood. The other drugs that are commonly, that you'll come across among patients in palliative care are the benzodiazepines. Now you're all familiar with benzodiazepines, which are drugs which are extremely used very widely for treating anxiety, sleeplessness, and epilepsy. They're very useful for treating status epilepticus, very useful for treating anxiety disorders, and so forth and so forth. So they're very widely used, okay? But they can also cause addiction. They can also, particularly in elderly patients, they can cause confusion. They can cause delirium. The person becomes confused, disorientated, and so forth and so forth. And in elderly people, the person can fall and injure themselves. And also, but if the person who has been taking large doses of a benzodiazepine for a long time stops taking it, they can have epileptic fits, grand mal epileptic fits. Remember, I mentioned that one of its properties is that it is anticonvulsant. So if the person takes it, stops taking it suddenly, they can have severe epilepsy. And this is important, again, in palliative care. Some of your patients would have been taking a benzodiazepine or diazepam. And when they get to hospital, it is stopped. So when it's stopped suddenly, you are at risk of the person getting epileptic fits and so forth. Then the next drug substance that I should mention, which is mainly used by poor street children, very common on East Africa, are called inhalants. These are the children who inhale glue, petrol, aviation fuel, plastic materials, and so forth and so forth and so forth. Now, these children find that when they inhale it, it produces an effect which is similar to alcohol, but they usually don't buy alcohol. But the experience is milder. But these substances get logged in the liver, into the heart, into the kidneys, where it causes damage, into the bone marrow, and it causes a wide variety of damage to these children, street children. And then the second last group I would like to mention are drugs which are known as psychostimulants that you've heard about. These are cocaine and amphetamines and others. So this is the use of these drugs are increasing in Africa. They are called psychostimulants because they elevate the mood and makes the person feel happy. It increases their alertness. It improves concentration, gives the person energy, and so forth. And these are the reasons why they are misused and abused. But they can easily cause dependence. The person becomes dependent, addicted to them after a very short period of use. And if they take too much very quickly, the person becomes abnormally hyperactive. It impairs somebody's judgment. Therefore, the person will be prone to causing accidents, violence, and after many years of use, it can precipitate a severe type of mental illness, which is called paranoid psychosis. Again, most people who get addicted to cocaine, amphetamines, find that if they inhale it or smoke it, it does not produce the desired effect. So they also inject it directly intravenously. And when they do it like this, because they share injection needles, they spread a lot of blood-borne diseases among themselves. You know, like, as I said, HIV, AIDS, hepatitis B, C, and so forth. And again, when they take it too much too quickly, it can cause intoxication and it can cause a cardiac arrest. You've heard from time to time of a famous film actress or a sportsman or a boxer who's in physical health, young, who falls down and dies suddenly. In many cases, they are taking one of these drugs in this category. I should mention this other psychostimulant, which may not be very commonly used in your country, but it's widely used in East Africa, in the Horn of Africa, Kenya, Uganda, Ethiopia, and the Arab Peninsula. It is a plant, a tree, an evergreen tree plant, which grows widely. And if you pick its leaf, a fresh leaf, and you chew it and swallow the liquid, it causes happiness and alertness, almost like cocaine and so forth. So it causes also some degrees of dependence, and it has got a substance on it which is called cathinone, which also causes dependence and so forth. For many years, its use was limited mainly to the Horn of Africa, the East African countries I've talked about, particularly Somalia, Ethiopia, and Kenya, and the Arab Peninsula, the Yemen, and those countries and so forth. Because it was very difficult to transport fresh leaves. After the leaves had been picked out of the plant, after 24 hours, it's no longer effective. So you should use it once while it's still fresh. But recently, traffickers have found a way of preserving it. So now you'll find cut available in markets in New York, in Tokyo, all over the world, and so forth. And then finally, I'll talk about opioids, which is one of very special interest for us. Opioids includes drugs like morphine, pethidine, codeine, and heroin. Morphine, pethidine, codeine, and others, of course, are extremely used legally for treating diseases in hospital pain under controlled substances. But heroin is illegal, it's illicit. It was discovered in the 1960s when they were looking for more powerful painkillers in addition to morphine. Morphine has been used for hundreds of years. But in the 1970s, 60s, they developed heroin, which they found was more powerful for controlling pain than morphine. But after using it, after a year or so, they found that almost anybody who takes it becomes addicted to it very quickly. So its legal use was stopped and is no longer manufactured legally. So only heroin that you hear about now is produced by underground laboratories. And it is one of the main problems, substance use disorders, which causes serious problems all over the world. You know the properties of opioids, why they're taken, is that they also have effect on the mood. They cause euphoria. But at the same time, they've got a very big effect on controlling pain, on relief of pain. And this is why they are so effective in relieving pain, and this person feels happy, and they complement each other. But when used under uncontrolled circumstances, they can also cause dependence very quickly. And unlike cannabis and so forth, it's a major cause of death. Mainly, either people who are addicted to it, it can cause accidental death. That is, they would have taken it and then they go to sleep. When they wake up, then they find that they forget that they'd taken it, then they take it again. And that causes an overdose, and then they don't wake up from sleep. The other way it causes death is by deliberate overdose. People who like to commit suicide and so forth, they take overdoses and it commits them. As you know, overdoses and deaths from opioids, particularly prescribed opioids, is a serious major problem in the United States, to the extent that the former president declared a state of emergency. Okay. When used intravenously, when people inject it intravenously, again, it puts them at risk of developing blood-borne diseases like HIV, hepatitis B and C, and so forth. But at the same time, I should emphasize that morphine is the most effective medicine for pain control. And this has been published many times by the World Health Organization. When it was first discovered for pain control in the 1860s, the physician called it God's medicine, because there was nothing, before that there was nothing that could control severe pain. And here is a drug. So I've really emphasized the importance of death rates, particularly in the United States. And I could also mention, I'm going to mention later on that, there's a side effect of it. I will mention it because we'll talk about it later on, or opioid-induced hyperalgesia, where when the person is being prescribed morphine over several weeks, and then it reaches a high dose, then you tend to get a paradoxical effect, whereby it stops controlling pain. Instead, pain increases as the dose increases. And the pain begins to spread to other parts of the body. So I'll mention this a bit later on. So, because again, I'll mention that despite what I've said about opioids, particularly about morphine, oral liquid morphine is used very widely. And here in Uganda, it is the main type of morphine which is used for controlling pain. Since palliative care was introduced in Uganda in 1990, then at the same time they introduced oral morphine, the one which is taken by mouth, not by injection and so forth. And we found that it is just as effective in controlling pain, like if being given by injection and so forth. The experience in Uganda after 30 years of using it is that it got very, very low risk of causing dependence. And I will mention later on that since in the 30 years, only about 3 cases have been found reported at Hospice, Africa, Uganda, of people becoming dependent on oral liquid morphine. The reason for this is that when taken in the stomach, it is slowly absorbed in the body, in the bloodstream very slowly, and it's also eliminated from the body very slowly. So it does not produce the euphoria, the happiness that you get when it's given by injection or when it's smoked. And there's a theory among pain experts that pain tends to protect against dependence on morphine, because very, very few cases of morphine dependence has been reported when it's being used for treating cancer. Almost all the cases of dependence that has been found, people getting addicted to oral morphine, is when it is being used for treating non-cancer pain, like sickle cell disease and another type of diseases, and so forth. So now, again, when you, as I said, there's a risk of people, we're talking about substance misuse disorders. So just briefly, let me mention to you risk factors. What are the causes? So what are the risk factors that can predispose somebody to become dependent on a drug or to develop substance use disorder? The first cause, of course, that is probably genetically transmitted. There's a genetic aspect of it because you find usually there's a family history of somebody of drug dependent. Some people become addicted to a drug because of ill health, because of poor health, particularly pain condition that cause pain. And that's why it's very important for you treating your patients in pain to be very careful and be on the lookout for the possibility that the person can become addicted to it. People with certain type of personalities can be predisposed to becoming addicted to drugs. People with a history of traumatic childhood experiences, child neglect, child abuse, sexual abuse are at risk, where there was family separation and so forth. And also, if a parent uses a drug, it's a risk factor that some of the children might also use it and become addicted. And then environmental factors that can predispose to use or dependence on the drugs is easy availability. The more easily available, the more people use it, the more people are likely to become dependent on it. And that's the examples are alcohol, tobacco, which are not controlled, and so forth. Advertisement until recently, there was a lot of adverts on television on alcohol, cigarette smoking, and so forth. These are very risk factors, particularly for young people. Price, the cheaper the drug, the more people will get access to it. Social problems, I will mention that. Some people begin to use these drugs to try to solve problems when they are stressful, having social problems. Then they begin to use the drug in order to solve their problems. So stress, family problem, marital problems are all risk factors. And then, of course, there are also cultural factors, particularly in some countries where drunk alcohol, use of cannabis is accepted as normal culturally. And young people, peer pressure, that they get pressure from other peers and so forth. So that is generally, as I said, an overview of the drugs and their harmful effects. So therefore, when you come across your patient in pain or any patient really attending palliative care and is dependent on the drug, be aware that in fact, they could also, in addition to the condition that brought them into palliative care, that they are also having all those other physical, social problems, depending on which drug they are dependent on. So what happens, therefore, a patient present with in palliative care, whether with a cancer, heart failure, and so forth, and is also dependent on any of these drugs, including alcohol. You can see that it can worsen the prognosis. It can worsen the physical condition of the patient. And it makes it very difficult to treat the patients. The patients who are taking palliative care, who are in palliative care, are already taking many medications for pain control, for relief of many symptoms. Now, if you bear in mind the side effects of all those other drugs, adds onto the side effects of the drugs that have been prescribed. So the problem of the patient is multiplied. Patients who are dependent with substance use disorder already have a lot of physical problems themselves, psychological problems, social problems. Now, again, your patients in palliative care already have a lot of physical pain. They also have a lot of psychological problems and so forth. So the problem is magnified. It makes it difficult sometimes to engage the families because people who are dependent on drugs do not interact well with members of their family. The family would have broken down. So it makes it very difficult for you to engage the family in the care of the patient. And many people who are addicted to drugs, because of poor memory and the habits, they don't comply with treatment. They don't comply with the medication. So it means that they will also not comply with the medication that you prescribe to them. They don't follow instructions. They don't follow your appointments and so forth, which worsens the prognosis. And it makes it very difficult for you to correctly assess pain of the patient. You need for to assess pain properly. The patient needs to be alert and clear consciousness. But now if the person is already addicted to alcohol or other drugs and are having withdrawal syndrome, then it makes it very difficult for you to carry out an assessment. And also, even more worse, I mentioned that when a patient who is addicted with substance misuse disorder stops taking whatever drug quickly, suddenly, then they develop withdrawal effect. And withdrawal syndromes cause physical and psychological symptoms, which makes the person very sick. So typically what happens when these patients are admitted to the hospital for palliative care, for whatever, the source of their drug that we're taking is stopped. So what happened immediately that within 24, 48 hours, they develop this withdrawal syndrome, which makes the person look worse than before. And it has been known that during this withdrawal phase, it's actually many of them complain of pain. So if the patient already had pain, drug withdrawal from a drug that they were taking worsens physical pain, which again makes it very difficult for you to assess and decide on the correct dose of morphine or whatever. And particularly cocaine, as you know, has got also is used as a local anesthetic. So it actually kills pain. So if the person was addicted to cocaine and they present to you with maybe cancer requiring morphine, you will find that the usual dose of morphine is not effective because there's what's known as cross tolerance. Okay, they therefore also require a higher dose of morphine, which is a challenge to palliative care workers because you know that the recommended dose for somebody of this weight is this much, but you've given that medicine dose of morphine for pain, but the person is still continuing to complain of pain and so forth because of this what is known as cross tolerance. I'll mention this in a moment later on. So just 2 more slides. So what do you do then? How do you manage pain in a person who is also dependent on the drugs and so forth? So the first thing to do really to be able to manage pain properly in a patient who is dependent on a drug, you have got to, first of all, to maintain the drug dependence, the substance use disorder. If that is not mentioned, if that is not managed, you will go nowhere, you will not go very far, okay? Either you, first of all, make sure that you treat the drug dependence, or you do it concurrently while also treating the patient with other palliative care medications and so forth. So that you know, this is the first step that you need to do because of all those physical and psychological complaints I've talked about. In the case of severe substance misuse disorder, it is probably advised, you'll find that it's necessary to involve an expert on substance use disorder. Treatment of substance use disorders with drug dependence is extremely complicated and very difficult. It requires specialists. And within psychiatry, there are people who specialize in managing substance misuse disorders. So if you're a patient, you present with pain and with cancer or whatever, and also is severely addicted to any of those drugs, particularly alcohol, opiates, cocaine, and so forth, if you got access to an expert on substance misuse disorder, involve them as my member of the team. And together, you should be able to assess the nature and the extent and the complications of the drug that has been used. Assessment in nature, what type of drug it is, how severe it is, and what are the complications of the person suffered. As I said, the complication can be physical, psychological, or social. I already mentioned that when they are admitted to hospital, they come under care, their drug of dependence is stopped. So the person experiences what's known as withdrawal symptom, which makes the person's condition look worse than before, and it can actually facilitate death. If it was a case of severe alcohol dependence, the withdrawal syndrome can actually cause death and so forth. And I already mentioned that be aware of what's known as cross tolerance. Tolerance is when the person requires a higher dose than before in order to produce the other effect. So if the person was taking alcohol or cocaine, as mentioned, they would have developed tolerance to pain. They require higher dose to control their symptoms. So when they therefore present to you, you'll find that they may require a higher dose of whatever analgesic and so forth. So there is a real risk. Again, one of the things when you get a patient with substance use disorder presenting in palliative care, one of the main problems that is encountered is that there is under-treatment of their pain because of this cross-tolerance. They usually require a slightly higher dose than other people of the same age and the same weight and so forth. And in many patients, the palliative care practitioners are reluctant to exceed the dose. So the patient continues to complain of pain. And this leads to another very important point I'd like to mention to you. There's something which is called pseudo addiction. Okay. Pseudo addiction makes the patient who is presented in palliative care, who is having substance misuse disorder, behaves like a person who is an addict to a drug. Okay, that is, they keep on complaining that the pain is not controlled. They keep on demanding that please increase the dose. When you send them for appointment, you give them one week supply, they come back after 3 days saying that I need more. They behave like an addict, and this is called pseudo addiction. The main reason is this, is that they may not be addicted. It is because of cross tolerance. The dose of morphine that you are giving them is inadequate. And so they are generally in pain. That's what's called pseudo addiction. Okay, so this is the second last slide. So management. So what do you do? I already mentioned that treatment of substance misuse is extremely complicated and it's prolonged. So what I'm doing here is just I'm going to mention to you the principles, what needs to do. And I already mentioned that the first thing for you to do in order to effectively manage pain or symptoms in palliative care is to treat the drug dependent. So you start with what's known as detoxification. Detoxification is the process by which you assist the person to come off the drug that they were addicted to. At the same time, you minimize or prevent the withdrawal syndrome. I've already mentioned that many patients who have got substance misuse disorders try to stop taking the drug themselves, but they cannot, because when they stop taking it, they get this withdrawal syndrome, which are very severe and forces them to take the drug again. So when in healthcare facility, we assist them we get them to stop taking that drug, but give them other medications that will suppress the withdrawal syndrome. And then the person will cooperate with the drug being discontinued and then other treatments being given. I've already mentioned that the patient will already be having a lot of physical, psychological, or social problems due to substance misuse disorder. So you have to address those as well. Because all those psychosocial social problems also worsen pain. If you don't address them, the pain worse. If you deal with them, the pain is reduced, and therefore you need a lower dose of morphine. Once the patient has stopped taking the drug, many people who are dependent on drugs are at very high risk of relapse. Many of them, after abstinence, after a few weeks or months, will relapse. This is well known. So we need, therefore, to do something which can prolong the period of their abstinence or can prevent them from relapsing. And now there are several drugs which are useful, and I think this is where you need a specialist in substance misuse disorders. In the case of alcohol, there are a deterrent drug, which is called antabuse, or disulfurium, some of you might have heard about, which can deter the person from taking alcohol. When they've taken antabuse in the morning, they cannot take alcohol for the next 24 to 48 hours. When they take alcohol, they become very sick. They get nauseated, feeling like vomiting, and so forth. So if this happens after several times, the person will avoid going to a place where there's alcohol, or sometimes just a thought of alcohol makes them feel like vomiting. So it is used as a deterrent. It's been used since the 1940s. And of course, it requires specialists. Then recent years, the last 20 years, other drugs which can abolish craving for alcohol. One of the reason people who are addicted to alcohol say they crave for it, a special need. When they don't take it, they really feel hunger for a thirst for alcohol, and they rush to drink alcohol because of the craving. But there are two drugs which are now being used widely. We can abolish craving, even abolish the pleasure that you get from alcohol. And these are called anti-craving drugs. One of them is called acamprosate, one of them is called naltrexone. Again, you need a specialist to prescribe them. In the case of opioids, people who are addicted to pethidine, morphine, and so forth, there are drugs which can be substituted instead of the person continuing, if they are dependent on morphine, pethidine, and so forth. They can stop those ones, and then they can be prescribed a drug called methadone, or there's another one called bupropion, which produces, if you like, the craving for the drug, but does not cause the harmful effect. If the person was addicted to nicotine, smoking, there are what are known as nicotine replacement therapies, which can be given, we can abolish the craving for nicotine, the need for smoking. Some of them can be taken as a chewing gum, others can be put as a skin patch, and so forth and so forth. So these are available in order to stop the patient from going back and so forth. In addition to this, all these patients require a wide variety of psychosocial support. Okay, counseling, support individually or in the family, involve the family, just like you do in palliative care. All these patients will need a lot of psychological to encourage them so that they stay off the drug and they comply. And there are a lot of specialist psychological therapies for those who are highly addicted to drugs, which can be given to an individual or as a group, or there's a condition called cognitive behavior therapy, again, which requires a specialist and so forth. And all of you, and many of these people, if the person was severely addicted to a drug, they will require rehabilitation. Okay, that is, if the palliative care condition is treatable, like as I mentioned, in the case of non-cancer diseases, the person must require rehabilitation. If these treatments outlined above are not working, then the person must require prolonged rehabilitation. And you have heard of the group called Alcoholic Anonymous, which are particularly useful for helping patients who are dependent on alcohol. Okay. So I think this is all I wanted to say. I should mention that patients who are addicted to these drugs are also at risk. Even when they present to palliative care, they are at risk of developing dependence to morphine, which we use for controlling pain. So you should be aware of this. If the drug dependence had been treated and the patient had been stabilized on morphine and the pains are controlled, but they are at risk of developing their dependence, transferring it from alcohol, from other things, and it can become high risk of getting dependent on morphine or pethidine and so forth. Also, I mentioned that if the patient in palliative care you are treating is suffering from a non-cancer condition, which is chronic, like sickle cell disease, severe arthritis, and so forth, which are chronic, and you are controlled their symptoms with morphine, be aware that they are at risk, and be on the lookout as you look at them that they can become easily addicted or dependent on morphine, even the oral ones I've talked about. So these are the sort of warning signs I'm going to finish with that you should look out. The patient who regularly returns before the review date, you have seen the patient today and you ask them to come after a month, giving them medicine. The person comes after 2 weeks. You give them 1 week's medicine, the person comes after 3 days saying that it is finished. And they give you different reasons why they've come earlier. Either the medicine was stolen, or they were robbed on the way, or the bottle was spoiled, all type of reasons. And when they come, they're always demanding higher dose. And yet, if the condition is stable, like sickle cell disease, then there's no need to change the dose and so forth. Typically, you'll find that all these patients, and this is our experience, in Uganda, you'll find that they are getting prescription from different doctors. They go to different clinic, private doctors. They go to the A&E department during the weekend and get more prescription from there and so forth. So they are getting drug from different sources. Be careful. This is a possibility that this person is getting addicted. And sometimes you'll find that instead of them coming for review, they send relatives or other people to come and collect the medicine for them. And yet, before you prescribe for them, you need to assess them. And if they send a relative, they cannot give the history and so forth. So, and sometimes you find that members of the family are also compliant with the patient trying to getting different medications from different places, or demanding higher dose and saying that the pain is not controlled and so forth. So therefore, you be on the lookout for this type to minimize the risk of your patient becoming addicted. So I think this is the end of this session. Thank you. Hello.
Thank you so much, Professor Huda. That was clear and very informative, well detailed. Thank you for that. Time is not with us. I will only allow one comment.
Sure. I welcome any comments.
I'll only allow one comment or question from the participant. You can simply raise your hand or indicate. I see a hand from trustee. Yes.
Unfortunately, I'm with Mr. Adam here. He's the one who's wants to ask a question.
Yes, please.
You can continue.
Okay. Thank you, Professor. Thank you, Professor. Yes. I'm sure he's okay. He's still on the line.
Yes, I'm on the line.
Thank you so much for such an informative. Yes, I just.
Hello, I'm sorry, your line is not clear. I can't hear. It has stopped. Hello?
Mr. A, are you still there?
In that case, thank you.
Yes, I'm sorry. The line did not appear. It went off. Can somebody repeat to me the question?
We didn't get him. Maybe he
Mr. A, we didn't get the question.
Okay. Yes, the question is how high should the nurse go giving this morphine to a patient in a situation whereby this patient is having this pseudo addiction, because there's a risk of overdosing this person.
Yes. As I said, there's a risk there, but you can minimize it by increasing the dose very slowly at the same time, offering the patient psychosocial support.
Okay. No.
Yeah, you increase very slowly over maybe after a week and so, and eventually you'll arrive at a stage where the person actually will report that I'm now okay, I'm now much better.
Okay, no.
Because if the pain is not treated properly, the patient might run away, or they might begin to look for additional morphine from elsewhere or other medicine from
Yes.
elsewhere. Yeah, which
Okay.
obviously does not help. Yeah, so increase very slowly. Yeah.
Yes, I'm answered. Thank you so much. Thank you.
Thank you.
Mhm.
Yes.
Anyone going once, going twice? Thank you so much, Prof. Thank you for a wonderful presentation.
Thank you.
In the interest of time, we will move to our case presentation for today, led by Ms. Tani. Prof, may you please share. Professor?
Yes?
May you please stop the screen sharing?
Okay, okay,
Thank
okay.
you, thank you, thank you, thank you, Prof.
Okay, okay, okay.
Tani, may you proceed?
Okay, sorry colleagues for the delay. I will just try to continue with the presentation. Our presenter today is Nonduduzo Tani, as Mr. Kelly has introduced me. We are having a new case today. Sorry for that follow-up. We are having a new case. It is a 20-year-old female client who has been recently diagnosed with neurofibroma sarcoma tumor. The main problem with this client is that the family is having a hard time accepting the diagnosis. They have many questions and want to know if anything can be done in terms of curative care for both ailments. Patient is also still very young and cannot fully express her feelings and thoughts on the diagnosis she has. The cancer diagnosis was also not properly explained to the patient and the family. The main concern on my side as a nurse is that I would love to have advice on the best approach in dealing with such a case, considering that the client is still very young, yet is already on advanced stage illness. So on assessment, the chief complaint of the client was that she has a metastatic tumor on the occiput. This tumor grew rapidly in a space of 4 months, and it's still growing rapidly. She has a massive soft tissue neurofibroma on the right leg since birth. She has also dropped out of school due to this medical condition. And recently she has had intermittent episodes of severe headaches, which have been recently accompanied by vomiting. The family is also struggling financially and cannot cater for basic needs of the client as they would like to. On assessment, physical assessment, The patient's right leg has gross muscle and tissue hypertrophy ranging on the size of 24 by 20 by 12.6 centimeters. This muscle atrophy is on the right leg and it has resulted in dislocation and distortion.
I forgot to explain to you what's happening. That Friday, when I was supposed to do the schema, I got a pre-lift. So when I was preparing to come to your place with the sibling, the lift, those people were about to leave. So I just said, give me at least save my transport and go with them. The principal.
Sorry, Dr. Dorothy.
And they spoke to me. I was in a.
Can you please mute yourself? Okay. Sorry, colleagues, for that. I was on assessment, on physical assessment. The right leg has huge muscle hypertrophy. As I stated earlier, the client was born with it, so now she uses a crutch to ambulate, and she also has the tumor on the occiput. Emotionally, the client appeared to be emotionally stable, which we can't say it was a good judgment because it was the first initial contact with the client, and she's also very shy, but the neurological status is normal. The client cannot fully express herself yet. Socially, the client's family has very poor finances. They lack basic needs like food. There is poor support from the father. The mother was reported to be deceased, but the brother is very loving and very supportive to the client. And with spiritually, the client has positive spiritual behaviors, as she did mention that she is she believes in the Christian religion and also is able to attend church regularly whenever her illness permits. And she also reads the Bible in order to strengthen her relationship with God. With the medical history, the client has had the neurofibromatosis since birth. She has had 2 below knee amputations, one in 2007 and one in 2011. The amputations were to try and control the tissue growth and to also try to fit in a prosthetic leg, but it kept growing. And also the family caregiver, the patient caregiver reported that after the 2 amputations, the medical staff, which was supposed to get back to them, they never got back to them about if they will be continuing with the prosthetic or not. And also the client has then been recently diagnosed with the fibrosarcoma tumor on the occiput since December 2022. It was diagnosed after the client had several severe intermittent headaches. There is no history of the main diagnosis in the family, and the client was started on palliative care on the 11th of this month, which means we haven't had a long journey with the client yet. And with the medications, the relevant past medications include prednisolone 10 milligrams. Unfortunately, we tried to look at her medical records. We couldn't get why she was given prednisolone and for how long was she given prednisolone. And also the family wasn't aware because it hadn't been explained to them. In the current medications, the client is getting amorphine 10 milligrams PO once a day, paracetamol, bisacodil, tegretol, and ferrous sulfate and folic acid. The tegretol was documented to have been used for the nerve pain since she's having neuropathic pain on the head. With the pain assessment, the client has had this pain for 4 months now. She said it's dropping in nature, and on the numerical rating of 0 to 5, the client said she is feeling the pain sometimes 3 up to 4, and the pain is intermittent. It is severe when she lies down, and it is relieved by medication. It does affect her sleep and affects mobility partially. But once she has taken the medication like the morphine and the paracetamol, she is able to achieve total pain control. And that was the assessment on the 11th of this month when the client was seen for the first time. And then the client was seen for the second time on the 24th of April. Unfortunately, nothing much in terms of assessing her could be done because she was in a hospital area, but we did ascertain that she was having overwhelming pain still in the same place where the tumor is. We suspected that it was due to intracranial pressure. This pain was being accompanied by nausea and severe vomiting, but it was then treated immediately on arrival at hospital. And the client was discharged just yesterday, which is on the 25th of this month. And the client's history, social history, the client is unemployed. She had to stop schooling when she was in Form 2, and she has no harmful lifestyle habits, and there are no relevant conditions in the family. With the directive orders and care planning, we didn't do much of it yet since it was first conduct, and we also felt we had to create a proper rapport with the client and have 2 or 3 visits before we can talk about it. Also, on those 2 or 3 visits, we'll be assessing the psychological maturity and assessing the readiness for the client to address such issues. And also with the systems review, her vitals were normal and the pain score was at 7, but the score is at 7 when the client hasn't taken any medication. Once the client has taken medication, she is able to achieve total control. With some of the other symptoms that come with her illness, she has sometimes she has that severe pain and mild anxiety, the nausea, which it was overwhelming, but luckily after being admitted to hospital, it has been totally controlled. So the client is still under observation if she still be able to hold meals and fluids in her stomach. And also her mobility is a bit severely impacted since she's had 2 amputations on the other leg and the other one. And the same leg is very huge in size, which is heavy for her. And then with the special investigations, we were able from her files to get a CT scan, which was done on the 8th of December, that's last year, 2022. And the findings for the CT scans were that there was a destruction of the parietal bone in the midline with a permeative pattern and peristolial elevation with a soft tissue mass occupying the extradural space and overlying the scalp tissue. And they also say there's possibility of metastasis from the neuroblastoma. So the radiologist had suggested that it would be good to do a biopsy. And he also found that the tumor in December, it was the size of 4.5 by 4.9 by 5 centimeters. But now I think, judging by the eyes view, it is almost double that size, because when looking at the patient, the size of the tumor is almost the size of the patient's head. Exactly. So I added here on the bottom here, the CT scan pictures from the client's results. As you can see here, it's the lateral view and here is the side view. As you can see, this was the tumor in December last year, but it has been growing rapidly since then. Right now, it was almost the size of the client's head, which means it has doubled or 2.5 doubled in size since the last CT scan. And with the further plan of care physically, we are planning to continue fully explain the diagnosis to the patient and the family, and also provide anticipatory guidance of the disease expected projection. And also we'll have educate the patient on general health promotion measures, which would include things like how to prevent the events like having the increased intracranial pressure, which worsens the pain and causes symptoms like vomiting. And also we'll continue to employ pain control techniques, inclusive of those that are non-pharmacological, and also will advocate for the patient for further medical assistance with multidisciplinary team, and also try to ask for assistance with funds like Palliative, in the hopes that maybe the client will be able to go to our neighboring country for further assistance. And then emotionally, we are going to encourage the client to verbalize their thoughts and feelings for proper interventions to be applied, because right now we are not sure how the client feels about having such an illness and then being born with such an illness and then having another one on top of the one she already has. And also we are going to try and ascertain the client's coping skills and also try and reinforce them. Socially, we will refer the patient and the family to a social worker and a psychologist for counseling and continuity of care. We also encourage the family members to be involved in the care of the clients, especially the father, because right now the main caregiver is the client's brother. And we also assist where possible with financial issues by conducting those who can be able to assist us, like the Children's Cup Foundation for meeting basic needs. We've been in contact with those from the Children's Cup Foundation, and they also say that they'd be able to assist with basic groceries, but we are not sure how frequently or for what period they'll be able to do it. But then we'll be still trying to get in touch with others who can be able to assist the family. And also we will try to assist wherever we can, still talking to those who are relevant with the social needs, as the client is no longer in touch with the main agent of socialization, which includes school, family, peers, and age mates. So, and the client also expressed that she wishes to resume school. And then spiritually, we will do continuous assessment of the client's sources of strength, hope, meaning, peace, love, and connection for the client. And then we will try to further explore her relationship between her spiritual beliefs and the client health to see if it's still continuously positive or if there are now negative factors. And also we will review the impact of the client's health condition on her religious practices. And we'll also assess how the client can be assisted with any spiritual concerns she might have. And also we will conduct terminal events planning when the client is ready. That is the advanced care planning and advanced care directives. So our main concern for this case, where we are asking assistance from your colleagues, is advice on which best approach to apply to best deal with this case. And can you also consider that she is still very young and she has these two major huge diagnoses which are not easy to accept even if you are an adult. So that is our case for today. Thank you, colleagues.
Thank you so much, Tani, for the informative presentation of the case. I will put that back to the participant, to the floor. Let's help this chart. It can be a recommendation, it can be a question, it can be an issue, whatever you feel like you have to say. I am giving you this opportunity. You can write on the chat box or you can simply raise your hand. Maybe is a hand there.
Thank you very much. It is a very complex case. By the way, I was just looking at the social, what we're going to do socially for the patient. One, you said the father is not in the picture, is not involved. And then spiritually, I don't know whether I went out because I don't remember what church the patient belongs to, and how often have they visited the patient? Do they have any influence on the care of the patient? Actually, does it belong to any community, spiritual community?
Thank you, Magdalena, for your question. Yes, the patient does belong to Umpolonjeni Evangelical Church. She is able to go there whenever she is not so severely sick, as she uses a crutch to ambulate. And the church, she said, it is partially supportive because sometimes they are there for her, but sometimes they're not that much there for her. Socially, her father is in the family home setting, but he is not that much supportive. It is only the brother who is very loving and very supportive to the patient. So we are yet to also talk to the father to try and understand how he feels about having a child who's having so many diagnoses. We also try to talk to the father and then maybe find a progressive way from the
Okay, thank you very much for the clarity. The other thing that I'm looking at is the fact that I think we will also need to have a meeting with the father, have a meeting with the brother, and then organize a family meeting after getting an individual interview. Then we organize a family meeting, and then maybe I think we can take it from there. To explain to I can say Dr. Dorothy, to explain why we are using prednisolone in the country is because we don't have dexamethasone to be taken orally. The only dexamethasone we have, which is readily available, is the injection, which is not okay for our palliative care patients. And I think because she was prescribed the prednisolone for a long duration because they were trying to control the swelling. Yeah.
Yes, thank you, Margaret Lamini, for your input. We will definitely put your advice into action.
Okay, thank you. Dr. Dorothy, I'll give you this opportunity. I see a hand from you.
Good afternoon to you all. Thank you very much for that case presentation and for the management of the patient. You've done a great job. Well done, because the patient has been chronically ill for quite some time. But I was wondering why you are giving the morphine. Was it once a day, 10 milligrams once a day? Is it a long-acting kind of morphine? Thank you, I submit.
Thank you, thank you, doctor, for that question. Unfortunately for us, the client was only referred for palliative, and we've only been able to see her on the 11th of this month. So the medications that were on the patient's file were mostly from her primary caregiver, which is the pediatric doctor from another facility. So she is the one who had initially prescribed the medication and the morphine for the client. Yes, and the morphine, we assume that it's the long-acting morphine. Otherwise, it was the doctor that had prescribed it. We are not sure what had happened prior to that, except for that the client reported, when I asked on it, the client reported that she had been having severe headaches, which I think it was due to the tumor that she was having. I'm not sure if you are answered on your question, doctor.
Yes, please, you have answered them very well. Thank you very much.
Okay, thank you so much. Before Margaret Lamini, I have there is a question on the chat box there from trustee. The question is what medication is the patient receiving from the cancer chemotherapy?
Thank you, Sister Mbata, for the question. Currently, the client is not receiving anything in terms of chemotherapy, whether it's palliative chemo or treatment chemo. They reported that the doctor on discharge referred them to palliative care and said there's nothing much that she can do with the tumor, as she feels that even if she can take the client to the theater for surgical removing, it might cause complications for the client. So that's why we were saying we are going to try and advocate with funds like the Palala Fund to see if there's anything that can be done with neighboring doctors.
Sister, are you answered? Oh, we hope.
Yes, yes, thank you so much, son.
Thank you so much, sister. I will take one last question from, there is an addition from Margaret Amin.
Thank you very much. Okay. I just wanted to add on what Tani said. On the morphine prescription, Dr. Every Eswatini hospice, we actually don't have the morphine at hand. Maybe it's because we don't have a resident doctor at the moment. All we can advocate is that for the morphine to be prescribed as per palliative care guidelines. Because as a certain hospice, we don't have the morphine, we don't have a resident doctor. And I think as I wrote on my report for placement, Dr. Dorothy, there's a need for a certain hospice to maybe to have one trained nurse in palliative.
Someone before that.
Oh, my addition was that as Eswatini hospice at home, we don't have a resident doctor, Dr. Dorothy. And maybe that is why we are always having problems with the morphine prescriptions, where we find that it is routinely prescribed like any other drug, like TID, QID, or BD. We only depend upon the doctors in our referral hospitals. And even the patients that we attend to are always or maybe referred to us by their relatives, community workers, health clinics, and maybe the actual hospitals where they, after being discharged, then they refer them to us with medication, the prescribed medication. Us is only to advocate that maybe the other doctors in the other hospitals are, we make sure that they prescribe the morphine as per the palliative care guidelines. And maybe to add on or echo on my report on my placement, I think I recommended that a certain hospice be considered when Institute of Hospice Africa has a sponsor, that they maybe take one nurse from a certain hospice to specialize in palliative care. Because at the moment we don't have, I don't know whether Dr. Dorothy is still there. Thank you very much.
Thank you so much for the addition, rather than maybe. I have one last suggestion from Dr. Pascal. I will read it as it is. While waiting to hear from other doctors, can you please adjust the morphine dose because clearly the patient is suffering? Yes, I think you mentioned that. Okay, thank you so much, Tim, for your presence, for tuning in for this wonderful session today. Okay, one last from Margaret Lynch.
Thank you very much, Lukele. It is directed to Dr. Dorothy. It is directed to Hospice Africa, Uganda, via Dr. Dorothy. I was wondering if we can make this relationship a regular thing, so that maybe we make a plan of the topics that we have for this year and submit them to you, Dr. Dorothy. And maybe you will help us with a facilitator on the topic.
Okay, thank you very much, Doris, for that request. We'll just put it in writing and then we see how we can support each other and best improve the knowledge for the team in order to improve the patient care and also improve their quality of life. Thank you very much, Doris and the team.
Thank you so much, colleagues. That marks the end of our today's session. There is a link on the chat box. Please go through that link and give us the feedbacks for today's session. We will appreciate that from you, colleagues. Also, the next presentation or the next session, upcoming one, will be on the 10th of May, to be on the Wednesday, same time at 1 o'clock in the afternoon. And it will be on physical treatment approaches. Thank you very much, team. God bless you. Last day.
Bye-bye. Thank you. See you on the 10th.